Actually, this topic is first I got a little scared when the topic was given, but truly the topic was actually very simple because we have ATA guidelines of 2015, we have ATA guidelines of 2025, that's exactly a decade. We are in an era of notebook LM, chat GPT. All I have to do is put these two documents in, it will churn out what's the difference, make 20 slides and come here. It would have been very easy. But look at the guidelines from 2009, 2015 and 25. Look how this document is increasing from 51 pages to 133 pages to 145 pages. Very heartening to note that the number of citations are increasing. So we guys as thyroid people are doing a lot of research. We are getting better data in. And to put all this after chat GPT in the time that I have got is too little the time allotted to cover the entire guidelines. So what I thought I'd do is I'll share my perspectives. I qualify as a high volume thyroid surgeon. I do more than 50 to 100 a year. 40 to 50% of my workload is redo surgery. These are patients whose surgery could be avoided or surgery could have been different. By having redo performance, it results in unnecessary physical, psychological, emotional, financial stress to the patient and the family. Most importantly, it affects complications, outcomes, and the patient's quality of life. I'll try to go through my talk quickly, and though it's a keynote, I'm open to some discussions because I may make a few provocative comments which you all may not agree with. For those of you all who want to exit the hall quickly, this is my summary slide. What's happened in the last decade? We have started triaging nodules in cancer into low, do less, or high-risk cases, do more, using diagnostic tools, pathology, large databases, and randomized controlled trials. We've started understanding the biology and molecular signatures to drive diagnosis, identify new path entities, and target therapy. And then we've got this boom of technology, remote access, non-surgical ablation, IONM. And like I said, I won't have time to cover this all. I'm not going to bore you all with a lot of data unless it's relevant, but I'll make a few comments so that everybody at whatever level of your practices would have some take-home message. So the first, thyroid nodules. And why I put this up, I see a lot of people having unnecessary surgery. If you put a probe on all of us in this hall, 2 out of 3 will have nodules. Clinically, 10 to 12% of people have thyroid nodules, more common in females, 18 to 50. Childbearing age, they need the thyroid in place. Remember that only 5% are malignant. FNAC is great. If you get a false positive, a false negative, it's less than 3%, and it triages patients into benign and malignant. Unfortunately, 1 in 5 is reported as indeterminate. The rate of malignancy in these indeterminate is 10 to 30%. To me, what happens is that pathologists who are well trained would give you on the extremes of the Bethesda staging. They would triage patients into a Bethesda 2, tell you it's a definite benign, or they'll tell you it's 5 and 6. But when you look at pathologists who are local cytopathologists, they tend to lump the cases in Bethesda 3 and 4. And here's a publication from the Annals of Medicine, highly cited journal showing this. So many of us practice in places where a pathologist will say it's indeterminate. So what do? Thyroid nodules are like barmaids. You don't know how good or bad they are till you take them out. So a lot of youngsters tell people 10 से 15% chance है कैंसर के लिए, remove the nodule. And patients have unnecessary surgery. That's not the way to go. The majority of these nodules can be observed. And we spent 2 decades on molecular diagnostics. Yuri Nikiforov in 2009 showed out of 32 patients who had 4 genes, he got 31 patients with malignancy, 97% positive predictive value, and he sold this business to the world. We went for 2 years. I've given 8 keynotes on molecular diagnostics. We went from 8 to 7 gene panel, and then we went to Afirma Thyroid, Seek Thyroid Generation, and the Rosetta test. All these have been endorsed by various associations, but they've never become standard of care. They have a lot of limitations, which tests, complexity, availability, it's not for every histology. So while we spent 2 decades researching on molecular diagnostics, it never became standard of care. And that's a message for all of you all, that you don't have to convince your patient to go for molecular diagnostics. Now look at indeterminate nodules and why you should not operate them. Indeterminate nodules, and this is again meta-analysis data, are mostly low-risk malignancy. The natural history is very indolent. The estimated risk of nodules indeterminate having cancer is, and life-threatening cancer, is 1 in 500 to 1 in 3,000. Look at the percentage, 0.03 to 20%. This is similar to the risk of dying from choking. And you should read Luke Morris's article in JAMA. The incidence of someone dying from an indeterminate nodule is lower than from someone dying from choking on food. Therefore, the message is we don't unnecessarily operate on indeterminate nodules. We need more work on diagnostic nodules. And keep in mind that you need to triage indeterminate nodules and not operate every patient who comes into your clinic. And how do you do that? You use the diagnostic triad of clinical features, sonography, and fine needle aspiration cytology. The clinical features we all know. Sonography, the larger the size, the higher the Thyroid score, the more chance that you need to operate these patients. Read the report. If it's spongiform, it's never going to be cancer. Don't operate that nodule. If it's solid, higher incidence of cancer. Size 2, going from 1 to 4, higher incidence. There's a recent meta-analysis just published this year that more than 4 centimeters, again the sensitivity drops. You have a lower incidence of cancer. And that may be more applicable in our country as well, but we operate these patients because of cosmetic and pressure effects. But focus on the fine needle aspiration cytology. And there's a lot of new compelling data coming. Nuclear versus architectural atypia. So your pathologist must give this. If you have nuclear atypia, and here I've quoted 2 papers there, they're very well cited, the chance of malignancy is double that if you have architectural. Repeat an FNAC, and again a meta-analysis published in Endocrinology in 2021. You stick a needle in the second time, you reclassify 50% into a lower stage, and you take another 15% into a higher stage. So again, you've got 2/3 of your nodules that you've understood. And most importantly, take a second opinion. And I would always take a second opinion from our 2 pathologists we work with, Dr. Borges and Dr. Kane, who are great thyroid pathologists. God bless Dr. Borges' soul. She's not with us anymore. But take a second opinion from a good cytopathologist. It's not only benign indeterminate nodules. Now, even if you have cancers, we don't operate cancers less than a centimeter. And that's another message to the youngsters. I see many people having a sono, total thyroidectomies with a 5 millimeter nodule. It's not correct. Cancers are indolent. Papillary cancers grow at the rate of 1 to 2 millimeters per year. You can have complications as high as 25% in the nerves and in the parathyroids. And we all know that many of us may have thyroid cancer. Here's autopsy data on 35 papers, 12,000 patients, incidence 4 to 11%. Other isolated papers, incidental thyroid cancers could be as high as 35%. So the world has moved to active surveillance, started first from the Japanese, the Koreans have taken it, and the US has also followed. Look at the number of patients with size increase, that's in the green bars. Maximum with the longest follow-up is 15%. Look at the number of patients who develop nodal metastasis, the red bars, 1.4, less than 2%. And look at the number of patients who convert to surgery. I'm sorry, those are the green bars, which will go to 15. So the blue bar is the size enlargement. The green bars redo surgeries or going for surgeries, and the red bars are the nodal metastasis. And now this is widely practiced. It started in numerous hospitals. You can see the timelines, and you can see that it's adopted by most guidelines. I'm sure in the years to come, we'll see our Indian thyroid guidelines there as well as part of this chart. Now, which patients are ideally suited? Yuan Brito has a great publication, but I prefer this adaptation of Yuan Brito's, he published in Laryngoscope Investigationals. But I prefer this because it triages patients into 3 groups. Those based on tumor characteristics, patient characteristics, and finally on medical team and various other factors. And really patients who have small nodules less than a centimeter, which are purely intrathyroidal, are the ones that you need to observe. They should be located bang in the middle of the thyroid, the green dots that you see. Those that come posteriorly or anteriorly, there is some debate. Anterior touching the capsule, which are the yellow dots, those are plus minus to operate, and the red is totally inappropriate. That is touching the posterior capsule because it can invade into the recurrent laryngeal nerve. We give active surveillance for all people more than 60, and it's based on the premise. We knew that as you get older, you have more aggressive tumors, but it's based on the premise of the Japanese. They followed patients, and they found the rate of growth was the lowest in those more than 60. The location, as I've shown you in this cartoon, and they should have no metastasis or doubtful nodes in the central compartment. So active surveillance is the way to go. And why I put this up is, again, I see a lot of patients, all of us work in cancer hospital, they have got breast, they've got larynx, they've got kidney, very, very aggressive tumors, have a PET scan, come in with a little nodule that you can see there, and the head and neck surgeon operates them when they're having a major lung resection, or they're on palliative chemotherapy for lung cancer. I don't think that's a correct thing to do. Please note that 1 centimeter is no longer the criteria. It's pushed to 1.2 to 1.3. The Italians do 1.2 to 1.3, and they believe there's inter-observer variability, but more importantly, when you put the probe, you compress the nodule. So 1.2 may be truly a number 1. And Alan Ho from MSKCC has gone up to 2 centimeters. Acceptance is lower. If it's less than 1, acceptance is 85%. When you convince patients who have got 1 to 2, acceptance is lower, 35%, approx 35. So remember, please don't push incidental nodules to surgery, even if they are positive. The index cancer takes precedence. As I tell my patients, aag kahin aur hai, usko pehle bujhao, then you come to us, we'll handle the thyroid. I give you a guarantee you will not die from your thyroid. So youngsters, no plucking out nodules unnecessarily. And even cancers you can observe, look at the entire clinical situation. What else has happened in the last decade? Molecular alterations. You can see across the entire spectrum of cancers, we have molecular alterations, PAP, follicular, anaplastic. It's changed the landscape of how we treat. Compelling level 1 evidence. We have the SELECT trial, the DECISION trial, the COSMIC trial, the ZETA trial, and you can see how they have all had an impact. Focus on my last line, and that's important for these are all multi-kinase inhibitors. They act on multiple targets. Kinase inhibitors have a clinical benefit that's response plus stable in 50 to 60% of patients, and this benefit lasts for 1 to 2 years. But we've progressed. We've gone to specific targeted kinase inhibitors. I'm not going to read this because I can't pronounce half the names. But you look at the basic change in molecular alteration, and you look at the drugs. You have dabrafenib, you have tramitinib, you have selpercatinib, and all of these are great. And again, focus on my last line. Fewer than 5% patients discontinued treatment when they had specific targeted, as opposed to 20% when they had multi-kinase inhibitors. I have a cardiologist mother that I'm treating. She came with pleural effusion. She came with pyrexia of unknown origin, described in thyroid cancers metastatic. She had columna. She's good. She just saw me a week back, more than 2 years after we've started her on a Dabra tramitinib combination. We've pushed the boundaries of these chemotherapies now, and we are using them in a neoadjuvant setting. And look at the landscape of the number of publications, all in 2024. Greg Randolph's multi-institutional, where is that? There it is on the right column. There's Latin American. Everybody now has pushed into neoadjuvant. Does this work? I put up Greg Randolph's 5 institutions, San Francisco, MD Anderson, Harvard, 17 patients. 11 patients underwent surgical resection with 10 receiving an R0, R1 resection. Good data. Look at the Latin Americans. 27 patients looked at various regimes, and you can see the third bullet is for papillary, the fourth bullet is for medullary, and the fifth bullet for ATC, and look at the response rates. They operate more than 2/3 of these patients. So we push now, don't operate, leave back R2 disease. You have a scope. And still more exciting, Greg Randolph's paper, and other people have done it. They call it the Lazarus effect. Lazarus, and some of you all have said this before in meetings, Lazarus was someone from the Bible. He died. Jesus Christ was in that area. Someone said, go and save my brother. So he came to the house, he walked to the room, and he said, Lazarus, come out. So Lazarus came out, and he was declared dead. So exactly the same, it's called the Lazarus effect. 7 fixed chords, given neoadjuvant chemotherapy, 6 started functioning. Now there's a lot that I can tell you. They look at type A, type B, epinurium, perinurium, length, but all that is different. That's a different talk that we need to give. But you can have function return. So if you have impaired cord mobility, keep in mind that you may need to use the neoadjuvant. And then we again have level 1 for the RAI guys, compelling evidence. Recombinant TSH established, more than a decade old. 30 versus 100 millicuries established. And no RAI for low-risk disease established. We've got a lot of technical advances, and again, I'm just giving a snapshot of what we have to do, and you can see them all there. For me, the majority are plus minus. They don't change outcomes. Robot has some advantage. Non-surgical treatment has some advantage. The other two just make a surgery safer. It's like having airbags in your car. You can drive a car without airbags and not die. But this is just like having something a little more, making your surgery a little safer. And I've just put up a snapshot of the various procedures that we do remote. Look at conventional, that is COA, the lateral approach, the MEVAT, that's Nicoli's approach, BABA, that's the chest to breast approach, and then you come down to robotic and then the oral, and look across the spectrum at the various cosmeses, bilateral operation possible, not operative trauma. I just want you all to focus on operative complexity. So the advantage that all these other procedures have is cosmeses. But please look at the number of stars for operative complexity. And the majority of patients that we do have complex operations. So thyroid outcomes are based on your expertise. So if you're occasionally dabbling in thyroid surgery, please remember these are very complex if you do remote access. And you must be well trained if you want to do remote access. The advantage is cosmesis, and the majority of patients heal well. 90% of our conventional heal well. So if you are gifted, like Dr. Tay sitting here in the front row, and that's your passion, do it. But otherwise, don't dabble in this. You'll call more harm than good. And why did this story come up? Because Korea had a national screening program. $400, they screened you for 5 cancers: breast, bowel, bronchus, prostate, and lung. Someone gave an additional $25, $30, put a probe on people's neck. And look at the number of cancers they got less than a centimeter. Some of them were less than 0.5 centimeters. And there was complication rates. And those of you who have been to Korea, go into their duty-free shop. These are pretty Korean women. You see more beauty shops in that airport than you would see alcohol shops. That's what we go into the duty-free to buy. So pretty ladies, 0.5 centimeter nodule, they would operate. And they didn't want a scar on the neck. So that's where robot was born. And the initial few publications, look at the number from Korea and the number from the rest of the world. Till today, the MD Anderson doesn't have a robust distant program. MSKC doesn't have a distant robust program. I've seen patients who are dabbled here with oral, and I've seen multiple nodules here, seeding of the tract. So you have to be an expert. I've seen a proctor in this country operate on a young girl who consulted me. I won't name the city. Fixed cord that can happen with open, trachea opened, esophageal, diverticulum, and sympathetic gone. Pretty young girl. So please be dexterous. Be an expert if you want to dabble in remote access. And then you have the various non-surgical treatments. And I'm quickly going to show you 2 data. Again, mainly it's come out of the Korean group looking at ablation for microcarcinomas, seems to score well on complication, lymph node metastasis, subsequently treatment time, cost, and quality of life. And they also recommend very, very strongly for those that cannot be operated and have a recurrence in the central bed, and it's a very, very strong recommendation. So these are treatments that are there, but it's not for people who are not experts. So for me, in technology, everything is on the back burner unless you're an expert and you're pushing towards that. Do I have time? 1 minute. I have to do this quickly. Bear with me, Kostub. I'll take another, maybe 1 minute more. They'll turn off my slides. They won't turn it off. Jyoti, give me 2 minutes of your time. You normally do that. Okay. So I have to put this because we've beaten it blue for maybe from Blake Caddy's time. Should we do a hemi or a total? 2009, anything more than a centimeter, Carl Villamoria's paper, do a total. 2015, you had 3, 4, 5 paper, Adam, MSKC, this, that, large NCDB database. They said that you could not do a total if it's less than 4 centimeters. But if you look at the 2015 guidelines, they left it very fluid. They said the decision depends on the patient, on the doctor to enable ROI therapy, follow-up preferences. There was nothing sacrosanct. And that's because we, as surgeons, don't do randomized trial. I know you all will jump up and say we need 30 years follow-up, 30,000 patients. We could look at different designs of non-inferiority. So this continues to be a debate. And here is 2025. The debate rages on. Look at T1, everything is still lobectomy and total thyroidectomy in 2025. Not 1 decade, 2 decades. We still don't know what to do. So everybody, there'll be a world tour. Everybody will jump up. They'll say 3.8 centimeter nodule. They'll look on the vernier calipers and say, I was told to do a hemi. They'll do a hemi. But science has moved on. We must have a philosophy. And I told you, I'll give you my philosophy. Now look what this is based on. 3 meta-analysis, all of them in favor of hemi. Look at the third column, no difference. Large number of patients, some 170, 13 studies, 10 studies, great journals. I'll put 3 more meta-analysis. These are in favor of doing a total thyroidectomy. Less complications, this, that, and the other. In science, for every 1 paper you quote, I'll quote 2 on the other side. There's always some data. So what do? I've put back the 2025 guidelines. The same guidelines that I cut, pasted, I made this because I've added that last column. Look at less than 1 centimeter, strong recommendation, moderate certainty. Look at bilateral 1 centimeter, less strong recommendation, moderate certainty. Look at the bottom, that's more than 4, clinical recommendation, moderate certainty. But look at in between, 1 to 4 centimeters, 2 to 4 centimeters, low certainty at the end of 2 decades. So we don't know the answer on what we have to do. But to me, do no harm to your patient. That's most beneficial. Don't go for total thyroidectomy because Dr. Cruz said, and screw your patient up. As Neeti said this morning, it's unforgiving, the complications of thyroid surgery. Look at the complications that are quoted widely by Julia Sosa and others. I don't believe them. Cruz's complication rate of 1 centimeter, थोड़ा बंद कर दो, उधर से 2 minutes. हाँ. So look at the complication rates. Low volume lobectomy 11.8%. High volume surgeons total versus lobectomy 14%. Highest risk is in low volume to do total thyroid 24%. This is Western data. And most of us who don't do high volume work, your complication rate will be close to 25%. You also have to give your patients thyroid. If you do a hemithyroid, only about a quarter of them, 22%, will need to have thyroid replacement. And giving artificial thyroid does impact on the patient's quality of life. Not very severe. There are 3 meta-analyses. One of them says in some groups, the other 2 4, but to me, they are all biased. So this is my philosophy. Less than 2 centimeters intrathyroidal, good age, always hemi, my book. More than 4 centimeters gross, widely invasive, aggressive pathology, total. No debate on that. The debate comes between 2 and 4. And to me, you should look at multiple factors. You should look at the age, you should look at the contralateral robe, you should look at family history, you should look at nodes, and that's why many of my patients, even if it's 2.8 centimeters, I do a limited exploration. I know people will say it doesn't make a difference. You don't want an aggressive histology to come. Sometimes I know on the opposite side there is a little nodule. I will then go for a total thyroidectomy because multicentricity does have an impact. Today, margins also have an impact, extra capsule. And if you read 2025, they differentiated between microscopic anterior and posterior margin, which came out of the 2015 ATA guidelines. But again, no time. So there are multiple guidelines. Don't just go and ape anybody. Many youngsters tell me at meetings, sir, ATA mein aisa bolte hain. The complication rates are 25%. Coastal does 1 paralysis in 800 patients. Those are for community doctors. So please read the guidelines very, very carefully. Adapt it to your practice. You must have individual decision making when there's no strong evidence, patient and family preference, clinical judgments, and geographical variation and infrastructure availability. Read literature. BRAF expression is different in Korea compared to the US. So the approach they'll use is different. So please apply it to geographical variation. And I end with this very, very famous, and many of you all have heard me talk on thyroid. And I put up Blake Caddy 40 years back. He said, biology is the king, selection the queen, technical maneuvers, and that's your robotic and your loops and your fluid optics, are the prince and princesses. Occasionally, the prince and princesses try to usurp the throne, they always fail to overcome the powerful forces of the king and queen. And to me, you must put emphasis on histology, age, margins, RAI, avidity, morbidity of surgery, look at randomized control trials and molecular signatures to fine-tune your care in thyroid. And to me, as I said, those are the major changes